Good afternoon, everybody. Welcome to Heart Failure Awareness Week and our kickoff webinar, which is being hosted by the Heart and Stroke Foundation and the HeartLife Foundation. We're very, very pleased to be here and excited to get this whole week of events started off. We have some great speakers for you today and are really looking forward to sharing this next hour with you. So today's webinar is Enhancing Virtual Heart Failure Care, Practical Strategies, Tips and Tools to Increase Access and Improve Quality. As part of Heart Failure Awareness Week, there's many other events going on that we'll share with you throughout the presentation. My co-host for today, I'm Patrice Lindsay. I'm the Director of Health Systems Change at Heart and Stroke, and I have the pleasure of co-hosting today with Marc Bains. Say hi, Marc.
Hello, everyone. Thank you for having me. I just want to acknowledge that I live and work on the traditional, ancestral, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh First Nations. I'm so happy to be here on this relevant topic. As Patrice mentioned, thank you again, Patrice, for having us. I'm the co-founder of the HeartLife Foundation, along with Dr. Gillian Code. We are a patient organization in Canada driven to engage, empower, and educate people on topics such as this to improve health outcomes. Looking forward to the great lineup of speakers that we have going forward.
Thanks, Marc. And I'm coming to you from Toronto, and Toronto is the traditional and unceded territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis communities. We respect the treaties that were made, acknowledge the past, and are dedicated to move forward in partnership with our Indigenous communities. And I encourage each of you to take a few minutes now that we're all, quarantining at home and working in place. Please take a minute to think about the territories you yourself are currently located in and the peoples that made it possible for us to come together today. So we'd like to take a minute to acknowledge that and ask everyone to do the same. So today's webinar is being recorded. There is a chat function. You're all in listen-only mode, so you won't be able to jump in, but we do have a chat function. Please use it as needed. And please, we encourage you throughout the presentation to start putting in your questions. We have three amazing speakers who have lots of knowledge to share with you. So in the question function on the side of the webinar box, you can enter your questions and we will be happy to respond to them at the end. Our speakers are all going to stay on time and we'll have lots of room for questions. If you need technical support, please contact the GoToWebinar tech service. Okay, we also encourage you to follow us on Twitter at Heart and Stroke is our Twitter account. And there will be an archive available at the end of this. We will post it and send you the link, as well as there will be an evaluation. For anybody who requires a certificate of participation, you can get those by completing the evaluation, and it's available at the end of that. We have some very exciting news to kick off our webinar. The province of Manitoba and the province of British Columbia have both launched provincial proclamations declaring Heart Failure Awareness Week. And this is a really important issue or a step because it shows the province's commitment to heart failure patients, and to improving care. So Manitoba had a proclamation that was delivered on the floor of legislation, and the MLA Michelle Babic also delivered a private member statement in the BC legislature. So we want to congratulate those provinces for this step and for being able to accomplish that. Like I said, this is Heart Failure Awareness Week. It's very busy. Tomorrow, there is a webinar being hosted by the Canadian Cardiovascular Nurses jointly with CHSF. On Thursday, Marc can tell you a bit more later that there's a whole day hosted by the HeartLife Foundation. And then Friday and Saturday is the heart failure update for family docs and other health professionals. So come and join us there. We're also doing a presentation, and cardiac rehab has also got some things going on the 5th. So a very busy week. Please join in as much as you can. We have three amazing speakers for you. Here's their pictures and where they're from. And then I'm going to turn it over to Marc to kick us off in a minute with our first speaker, Wayne. So just to remind you, our goals for today are to describe the current landscape and challenges in heart failure care, and we know that there's many, but really our whole theme is virtual care for Heart Failure Awareness Week. So really thinking about the shift to virtual care last year, But in fact, in heart failure, there's been a lot of virtual care happening already. And both Kyla and Stephanie will talk to you about that and how it's already been integrated in their practice and how it's expanded during this time, but also when it's appropriate and not appropriate to use it. So really looking some great information that will come. And then we're also going to provide you with tips and tools on how to improve care during these challenging times. So Marc, I'm turning it over to you.
Thank you so much, Patrice. And I mean, yeah, what a busy week it is for heart failure. And it speaks, I think, now to the emphasis that's being put on heart failure nationally. I remember back in 2016 when Jillian and I first met at a heart and stroke roundtable, and there wasn't a lot of conversation happening in a coherent effort across Canada. But here we are now with healthcare professionals, people with lived experience, and our two groups working together to provide this knowledge. And it's without further ado that I introduce with pleasure my good friend Wayne Sandvik, who I met just a few months ago through HeartLife Foundation. Wayne joined one of our Wednesday calls that we have, and his story was inspiring. And every week he puts a smile on my face and inspires me to do more. And Wayne's here to talk about his lived experience with heart failure. So without further ado, Wayne, I pass it on to you.
Thanks, Marc. Appreciate it very much. Good afternoon to the Heart and Stroke Association and to everyone that is registered, to our moderators and to my fellow presenters. My name is Wayne Sandvik and I live in Sault Ste. Marie. It's my honor to be here and to speak with you about my experiences with virtual heart failure care. Before I begin, I think it's important for a quick backstory so you'll have a better understanding of my current health before I talk about my experiences with virtual care. January the 21st, 2017, I had what was called a major heart attack that occurred in my circumflex artery. My wife heard me fall and called for an ambulance. It's surprising how much I remember. I remember the ride to the hospital, being wheeled in to emerge, and Dr. Rishi Ghosh saying to me, "Mr. Sandvik, do you know what's happening?" I responded by saying, "I'm having a heart attack." And I also said, "I don't want to die." Now, at the time, the Sault did not have a cath lab, and every year, hundreds of patients were being flown by air ambulance to Sudbury or Toronto. Now, normally the middle of January means some pretty cold temperatures here in the Sault. Not so that year. In fact, it was a foggy day, which means the air ambulance wouldn't be flying me. Just my luck, global warming at the worst possible time. Since the air ambulance was not prepared to pick me up, Dr. Ghosh was faced with a challenge. Not only did he have to shock my heart to get it back into rhythm, but he had to try to settle me so that he could drive me by ambulance 300 kilometers to Sudbury. So my first experience with virtual care was with Dr. Ghosh and his team at Sault Area Hospital as they spoke with air ambulance, cardiologists, and who knows how many others as they tried to save my life. Can you have the first picture, please? There's a picture of me and Dr. Ghosh 2 months after my heart attack. This man saved my life. It was over 8 hours from the time of my attack until I began being treated in Sudbury. I received 2 stents and spent 13 days at Health Sciences North. I left with the diagnosis, congestive heart failure. Before I go further, I just want to say that the quality of care I received here in the Sault and in Sudbury was outstanding. Canadians should be very proud of our healthcare system. Now, as you're aware, with a diagnosis of congestive heart failure, patients usually face further complications. I've had numerous side effects from the meds I take, as well as some numerous health issues, including pericarditis, pneumonia, bronchitis, atrial fibrillation, and hyperthyroidism. Regarding the atrial fibrillation, in late 2017, I had an appointment with a cardiologist at Toronto General. While waiting in his office, I briefly passed out. I was quickly diagnosed with AFib, and fortunately, while I was there, they inserted an ICD, an implantable cardio defibrillator. It's amazing how many ICDs they insert into patients. It's like an assembly line. I remember asking them about it, and they said the only time they stop is when a heart transplant becomes available. Next picture, please. Here's a picture of me with the scarring that occurred. A little gross. There's a picture of the scarring that occurred after I removed the bandage that they covered my ICD with. And yes, removing that bandage hurt a lot. So after everything that's happened, just over 1 year after my attack, I've got another picture, please. A picture of me and my business partner, along with the mayor and the CEO of the Chamber of Commerce as we opened a new office. This picture is proof that after everything I've been through, there's still a reason to smile. Over the past couple of years now, I've had regular appointments with the pacemaker clinic at the Sioux Area Hospital. This is where I personally experience real virtual care. I'm in a private room with a 40-inch high-def television and a cardiologist from Toronto at the other end. Of course, my wife is allowed to join in. Laura or Rhonda get me all hooked up with a few electrodes, read the results, and then tell the cardiologist how my pacemaker is doing. He reviews his notes, asks about any medication changes, and how I'm feeling. He's even asked about my mental health. My wife really appreciated that one. Sometimes they'll make adjustments to my ICD right there, and he's even made changes to my meds. Through it all, the doctor is prepared to answer any questions that my wife or I may have. These appointments usually take 20 to 30 minutes, and a report is also sent to my local cardiologist. This is all amazing. I'm being taken care of by a cardiologist that is 700 kilometers away, and I know that I'm being well taken care of. If this virtual service wasn't available, I'd have to travel to Toronto, which means booking a flight, an overnight stay, time away from work, all for a 20 or 30-minute appointment. Canada is a huge country with cities, towns, and villages that don't have as many doctors that we need or the specialists. I'm convinced that virtual healthcare should be available to all Canadians. I also believe that virtual care is not confined to the use of video technology. Consider the pandemic we're living in. How many of you have made a call to a patient or were on the other end and received a call and had that appointment over the phone rather than traveling to an office or clinic? I've had phone appointments with a nephrologist, a hematologist, and my family physician. The nephrologist treating my thyroid has even provided me with his email address in the event I have questions or concerns. In all of these cases, I felt like I was being well taken care of, and as long as the doctors have recent blood results, sometimes an in-person appointment isn't necessary. In fact, because of COVID-19, it's probably safer. This next picture, please. This is why I stick around, my family. My kids are in their early 20s, and I want to be around for them as long as I can. And all through my heart problems, my wife Gina has been there for me every step of the way. Her love and support mean everything to me. Next picture, please. My last picture is the two of us at a Greek restaurant on the Danforth in Toronto. As soon as this pandemic is over, we're going back. So my takeaway is quite simple. Virtual health failure care works, and I urge everyone to get that message across to as many people as possible. Tell your colleagues, your friends, patients, and politicians that virtual heart failure care, indeed even robotic heart surgery, is here. And Canada needs to acknowledge that. Because once we do that, we can begin the work that's needed so that Canadians everywhere can get the best treatment possible and show the world how it's done. For those of you still here, thank you. I appreciate the opportunity.
Thank you so much, Wayne. That was so moving and so fantastic. And your family is so amazing. The supportive family and others, friends is so important, and you've really demonstrated that. We're very grateful to you for being here.
Thank you.
So our next presenter is Dr. Stephanie Poon. Stephanie comes to us from Sunnybrook Hospital in Toronto, where she's the medical director of the Heart Failure Clinic, or the Heart Function Clinic. She's a great volunteer with Heart and Stroke, and we've recruited Stephanie, and she's almost one of us now. We've reached out a lot lately, and Stephanie's been fantastic. She's also well-experienced clinician and is going to share a lot of her perspective and tips on heart failure care in a virtual world.
Thanks very much for that introduction, Patty. Today, I'm going to be talking a little bit about how we started incorporating virtual assessments into the care of our patients with heart failure at Sunnybrook. So hopefully I can get control of these slides.
I'll try it again, just a sec.
Okay. Or you can advance them for me. Still not, oh, there we go. Was that me or you? Okay, well, these are my disclosures. Although it is obvious that I will essentially accept money from anyone who wants to give it to me, the Heart and Stroke Planning Committee and speakers of this webinar are the ones who have complete control over the content of today's program. Also, all of the recommendations involving clinical medicine that I'm making here are based on evidence that is accepted within the profession and conform to generally accepted standards. So I'd like to start off by telling you a little bit more about where I come from. I'm the medical director of the Heart Function Clinic at Sunnybrook Health Sciences Center. Our team consists of 1 full-time and 2 part-time cardiologists, as well as 2 nurse practitioners and 1 administrative assistant. On average, we are currently seeing 15 to 20 new referrals per month, and cumulatively, we are on track to have about 1,550 patient visits this year. When the Heart Function Clinic was first founded about 7 years ago, our primary mandate was to see patients who had recent ER visits or hospitalizations for heart failure within 2 weeks of discharge in order to reduce 30-day readmission rates. However, we also see complex and high-risk patients with heart failure, such as those who are given a new diagnosis of heart failure with reduced ejection fraction or HFrEF. Then when these patients stabilize, we graduate them to routine checkups and see them every few months or even on an annual basis. So if you've ever been to our clinic, you will know that we spend a lot of time with our patients. Our typical assessment includes a complete history with medication reconciliation, physical exam, and review of investigations. However, we do spend the vast majority of our time teaching our patients and their caregivers all about heart failure, including strategies that promote self-management. This includes educating them on the importance of sodium and fluid restriction, as well as how to adjust their diuretics according to their daily weights. And everything was going great until last year, when news of the COVID pandemic broke out. During that first wave, everyone was told in Ontario to remain at home except for essential purposes. For once, our waiting rooms and clinic in the ER were completely empty. You could literally see dust balls blowing down the empty hallways like some bad Western movie. People were just afraid to come to hospital. And during that time, we realized that in order to continue giving help to those in need, we would have to create a new model of care. We quickly pivoted and officially started our virtual stream in March 2020, and now approximately 35% of our patients are being managed virtually on an ongoing basis. When we first started our virtual stream, it consisted of all the patients who are undergoing their routine 3, 4, 6, or 12-month assessments. However, these patients had to be completely stable to stay in the virtual assessment group. Namely, they had to have stable symptoms, stable weights, and stable renal function. If these patients did not meet any of these stability criteria, they would be transferred to the face-to-face or in-person stream. Additionally, we continued to see patients who had a new diagnosis of HFrEF and were still undergoing medical optimization, as well as patients with a recent heart failure hospitalization or ER visits in clinic. So when we first started this, we were often asked why all the appointments could not be conducted virtually. There are 3 main reasons for this. First of all, if patients are feeling more short of breath, we need to physically examine them in order to determine if this is related to heart failure or not. Additionally, if patients have gained more than 5 pounds of weight from their usual baseline, we need to examine them to confirm whether this is dry weight versus fluid retention, because as you all know, not all weight is water weight. Many people have been gaining weight simply by staying indoors during this pandemic, eating more, and becoming more sedentary. Again, we can tell whether it's water weight or not by looking at the jugular venous pulsation in the neck, listening to the lungs, checking the abdomen for ascites, and seeing if there's any peripheral edema. If a patient's weight is significantly increased or even decreased by more than 5 pounds, this often necessitates adjusting their diuretic sliding scale, which will require an in-person visit to determine their new dry weight. And finally, if the blood work shows worsening renal function, we need to physically examine the patient to determine whether this is related to dehydration or fluid retention, because either of those things could lead to acute kidney injury, but they're on obviously opposite ends of the heart failure spectrum. So these are not things that can be easily assessed over the phone or even by Zoom or OTN. Also, for patients who have been newly diagnosed with HFrEF, namely those with a left ventricular ejection fraction of 40% or less, the Canadian Cardiovascular Society heart failure guidelines state that we should initiate standard therapies as soon as possible and titrate every 2 to 4 weeks to target or maximally tolerated doses over 3 to 6 months. And this is due to the fact that patients with an LVEF of 35% or less are at higher risk of sudden death and may need to be considered for a defibrillator to help prevent this if their left ventricular systolic function does not improve with medical therapy. However, the medications used in the standard treatment for patients with HFrEF have side effects. Some may lower blood pressure, others lower heart rate, some may impact renal function, and there are also a few which tend to raise potassium levels. An in-person assessment may be necessary to monitor all of these parameters unless you are fortunate enough to have access to telemonitoring data, for example, the Medley app or telehealth home care or even CardioMEMS, and frequent blood work. Regardless, if their renal function worsens, they may be better served by being seen in clinic so you can determine whether this is related to the side effect of medications or suboptimal management of their volume status. We also reserved in-person assessments for patients who had had a recent hospitalization or ER visit because we know that these patients are at high risk of being readmitted again within 30 days. This figure shows that patients who saw a familiar physician within 14 days, as illustrated by the column on the right-hand side, were less likely to die or to be readmitted to hospital within 30 days compared to those who did not receive any follow-up at all, which is in the highlighted column on the left. Finally, I cannot stress enough the importance of not delaying or deferring routine outpatient care. This is a dashboard from the Canadian Cardiovascular Society, which highlights the impact of public health policies on cardiovascular care in the context of the COVID-19 pandemic. As you can see, in that first wave around April 2020, illustrated in the latter half of this figure, heart failure hospitalizations shown in white dropped dramatically since people were afraid to come to the hospital and they avoided everything, tests and appointments, for as long as they could. However, by the time they realized that they needed to come into hospital, oftentimes they were too sick for us to assist them, and that's why we also saw a huge spike at the same time in in-hospital mortality, which is shown in red. So, for those patients who are stable enough for virtual assessments, this is a checklist of things you need to have with you for the appointment to go as smoothly as possible. Remember to get blood work about 1 week before the assessment. Have your weight record and medications on hand. If you have a blood pressure cuff, writing down your heart rate and blood pressure measurements on the day of your appointment can be useful. For healthcare providers, it is helpful to give patients a reminder call about what items are on their checklist before the appointment. If you have access to it, telemonitoring data can be a great adjunct to give you a better overall picture of their clinical status. And finally, make sure you have a mechanism to send lab requisitions, prescription refills, and patient education materials or resources. So to summarize, virtual appointments are now likely going to be part of the new normal of providing care to stable patients with heart failure. However, high risk or decompensated patients should still be seen in person. And finally, perhaps most importantly of all, please make sure you do not defer outpatient appointments or tests until COVID is over, since we know that delaying care results in worse outcomes for our patients. Although COVID-19 has brought along many challenges, I think some good has come out of it too, and I believe that the shift to virtual assessments is definitely one of those positive things that will continue to help us improve the way we deliver care to our patients with heart failure, even when this pandemic is finally over. Thanks very much, and I look forward to answering your questions at the end.
Thank you so much. Thank you so much, Stephanie. Appreciate that. And, of course, finding those silver linings is so important, and those tips with virtual health appointments, I know I'll use those going forward, as well as, adapting to that new normal, as you emphasize, and creating that balance between virtual and in-person. Now is my pleasure to introduce, and I'll say this right, nurse practitioner from the Heart Failure Clinic in Winnipeg. We all have love for our nurses, of course. We see them day in and day out, and they play such an integral role in our care. Kyla Siatecki. Kyla, I'll hand it off to you.
Perfect. Thank you so much for the introduction, Mark. I also want to thank Wayne for sharing his very moving lived experience with us, and as well as Dr. Poon for her expertise on delivering heart failure care virtually. She's done such a great job. I hope I can add something to this. As Mark said, I'm a nurse practitioner and I work in the heart failure clinic in Winnipeg, Manitoba at St. Boniface Hospital. So just I'll quickly point out my disclosures, but I'll echo what Dr. Poon had mentioned with no influence, and that working with Heart and Stroke and HeartLife Foundation for this presentation. So that's all there is really to say about that, but they're listed there. So I just kind of wanted to touch briefly on our shift in landscape is kind of what I try to refer to it. So about shortly over a year ago when COVID-19 hit us and things had to change. But echoing again what Mark said, that virtual care is not new. So where we had sort of come from is we operate a shared care model for heart failure clinic here in Winnipeg. And we were seeing about close to, if not at 100% in-person appointments. That being said, we were still doing a generous volume of phone calls for intermittent care needs, follow-up plans, and review of results with patients. So it wasn't incredibly strange for us to be delivering care through a virtual, i.e. telephone model. And where are we now? So roughly about 13 or 14 months after our forced shift, we do remain shared care. That hasn't changed for us, but about 75 to 80% of our scheduled appointments are done through virtual or telephone modalities. Typically telephone-based, as is the preference of most of our patients and probably most of the staff as well, but we do have access and will occasionally use video conferencing as well. We have continued to provide, have patients access care through phone calls for their intermittent needs, so that typically hasn't changed for us. And our in-person appointments are selected for patients depending on their complexity, access to services, access to home monitoring equipment. There isn't a strict algorithm, but it's just sort of our clinical judgment on who we bring in versus who we can keep at home. So initially, as things shifted for us, I asked myself, and I think the rest of my staff members could echo this, is we had asked, is this safe and is this effective? It was just a change in our norm, and change is difficult for everybody. So some of the challenges that we noted is we were missing the visual component, either fully with a telephone appointment or partially with video conferencing. So there was some information that we would typically be missing sometimes for those appointments, and getting used to that and finding different ways to get that information. We could potentially be missing nonverbal cues and a human component of connectedness and connection, which we establish longstanding relationships with our patients and their caregivers, and so sometimes we missed a bit of that. Sometimes we found that there was just a phone appointment mentality on both sides of things. So in speaking to a patient, if we had questioned, oh, you had spoken to your kidney specialist, i.e. your nephrologist, and they said, oh, just a phone appointment. They just called me on the phone. And so it was more of a shift in mentality for all of us all around. Patient preference, and it could have gone either way. Some patients preferred and sort of let us know, I'm happy to wait until things quote unquote calm down and then I'll come in person. And sometimes they preferred to stay at home, and they were accepting of that change in care delivery. A big challenge was lack of access to data, including home weight if a patient didn't have a scale, blood pressure and heart rate if they didn't have that type of equipment at home. So that's definitely been an ongoing challenge for us. Sometimes what we found is that for new consults is we're over a year into, primarily virtual-based appointments now, and there were some patients that for the entirety of their care with the heart failure clinic was all virtual. So no team member had ever actually laid eyes on them. There was nothing that triggered us to bring them in for an in-person appointment. And so they'd spent the entirety of their care with telephone appointments. So it was a little bit alarming to us at first, but I think we're warming to the idea. And then expectations from us for the patient and from the patient for us. So trying to work through those challenges, going back to that just phone appointment mentality, and then our expectations from them, which I'll get into in a little bit. One thing on the admin side is we did have a lot of missing appointment letters. A lot of this is just due to some of the mandates handed down that we're not allowed to book so far in advance because the current climate with the pandemic is ever unknowing. So we don't want to have a bunch of made appointments and then cancel. So short booking leads to a lot of missing appointment letters. Letters that looked differently from the normal letters that patients were receiving, and so it led to confusion for them. So we've had to adapt and change, and sometimes even involve some patient input into what are they looking for that makes the nature of the appointment look more clear for them. Sometimes connection difficulties with access to reliable phone lines and or internet. It's not rare for our patients to not have internet or even reliable phone lines. As well, difficulties navigating the technology, both for the patient and the family, as well as for us. So it's a whole new world in terms of Zoom. We use Microsoft Teams, and so really learning that technology and how to teach patients how to do it. So learning it for ourselves and then being able to teach that to them. And then with the COVID-19 pandemic, we've had a shift in staff resources, sometimes leading to a deficit in staff members. So really requiring us to adapt and change, usually with less staff than we had originally to do the job. Some opportunities that we saw with the shift right off the get-go. So of course we were able to improve access to all, but particularly to those in our northern, rural, and remote communities, which is really important. Sometimes people are coming from fly-in communities, and oftentimes weather would cancel their flights to the heart failure clinic 1, 2, even 3 times in a row. So this really helps to address that issue. And then as well with people who have mobility challenges getting into clinic. We all appreciated for the patients, and they appreciated it for themselves, less driving, less travel time, and less money spent on parking. And then of course, less missed time at work for both the patient and the caregiver. So that's really important as well. Aside from the extra admin sort of process that sometimes added a little bit more complexities, which is important to note, is a bit more of a streamlined process for the patient. They're home and they're waiting for the call versus driving to the clinic, finding parking, navigating through the hospital, all of the extra processes in terms of screening for COVID-19 symptoms. So it was quite a bit more streamlined for the patient. Can't argue that it's so beneficial that we're coming to them versus them coming to us. So it results in a greater opportunity for patients to take control over their care. Overall, we found there was better availability for appointment times. There was reduced anxiety for patients and caregivers with having to come to a health facility during the current pandemic. And so giving them that opportunity to remain at home was very appreciative. We were able to generate a little bit more, increased frequency of appointments and thus titration of their medical therapy, which is really important to achieving heart failure care mandates. Virtual appointments rather than telephone allowed us to visually see the patient, giving us a better perspective that simply a telephone appointment couldn't give. And then of course, choices and preferences. So as I said, it sometimes fell on one way or the other in terms of patient and caregiver preferences for in-person versus telephone, but we were able to just accommodate a little bit better. So what we've learned and how to amplify the opportunity. So looking back on things and how they've evolved, if the opportunity did present itself, I don't believe we would return to our pre-shift landscape entirely. I think that we would continue to change and adapt how we do what we've always done with some modifications as we go. We have found that the virtual and telephone care is effective and beneficial, and patients will often prefer it. The decision on virtual versus telephone does depend on a variety of factors. What comes to mind probably more frequently is access to services and devices so that we can accurately assess and titrate therapy over the phone or virtually through video conferencing. Generally speaking, we usually need a bit more information from the patient right from the beginning. So generally new consults, if a patient has an email address or internet, information about their local lab for faxing requisitions, because we won't have the opportunity to hand it to them, is really beneficial and helps to streamline some of those virtual appointments. A decision tree or guidelines on how to navigate the care going forward. So ever evolving on choosing who's in person versus who can and should be done through a virtual appointment. As I said, sometimes comes down to critical thinking or judgment. But I think as Dr. Poon had shared, a nice decision tree to help make it very simple and streamlined onto who belongs in which type of clinic or stream. A couple of points that some of my colleagues and I shared prior to this presentation was to try and treat the telephone appointment like a regular appointment. And that often involves having clear expectations pre-appointment, during the appointment, and post-appointment. So what was shared before is having blood work done in a timely manner prior to the appointment, having your weight, blood pressure, and heart rate measured prior to your appointment, and that you're in a quiet space and you have sufficient time to actually complete the appointment. And that's true for both the provider as well as the patient. It's important that since if you're doing a telephone appointment, you might miss those cues, and so choosing active listening rather than risk interrupting the patient and their story. And however you can, involving the family and caregivers, so using speakerphone a lot if you're doing a telephone appointment. Plan with the patient and stay flexible. So what I have found personally is sometimes for complex plans that can be a little bit more overwhelming over the phone rather than in person. And so sometimes reviewing with the patient the plan and making sure that they're understanding of the plan and its complex nature. And for that reason, endorsing the teach back method so that you can be clear you're using a concise messaging with your plan and follow up for the patient. Sometimes we've resorted to teaching the patient and caregiver how to do certain physical assessments. So that not only involves blood pressure measuring, as we know that the incidence of that has increased in the community, but also teaching patients and their caregivers how to check for swelling in their extremities, so pedal edema, and that helps us to determine accurate volume assessments. As a team, what we believe to amplify the opportunity for virtual care is with shared care models, if you do have one, to be consistent in your messaging and care. Make sure that you're following the same guidelines and that everybody's updated on the plan. It can sometimes change from day to day, so making sure all team members know what the overall plan, messaging, and care is. Suggesting meeting regularly to discuss what's working, what needs to change while delivering care in an evolving situation. So what's worked, what are your victories, what are your challenges, and where do we need to change things up so that we can better address some of the barriers that we're facing, and supporting one another through the change. Some people are better at managing the technology, so making sure that we're all up to par on the same level. And then always thinking about the style of care and the delivery of your care and finding new ways to deliver when you're not in person. Coming from the clinic being 100% in person, we've really had to adapt and evolve what we do and really had to look internally to try and address some of these barriers or challenges that we're just not used to dealing with in the virtual world. So just to summarize, COVID-19 has forced us to shift how we deliver heart failure care. That being said, we know that virtual care is not new. However, the challenging timeframe we've had to shift has presented us a great opportunity to evolve. All the while, the core goals of heart failure care have not changed, but how we deliver it has. This evolution has allowed us to, on an individual level, simplify our process and amplify a patient's control over their health care, and decision making. On a system level, we can improve access and make it more equitable for all of our patients. When looking back to the beginning to answer my initial question, virtual telephone care, we find it to be safe and effective, which is very important for us overall. Thank you.
Kyla, thank you so much for that excellent presentation, and thank you to all of our speakers. You've all been amazing with so much information. I invite all three of you to come back on camera. So Wayne and Stephanie, please join on camera. We do have some questions, and we're going to put them out there, And thank you. Keep the questions coming. I'm going to kick it off with a really important question. And I'm going to invite all three of you to answer it. And I'll ask maybe Stephanie to start, and then Kyla and Wayne. This week is also Mental Health Week. And mental health is such an important part of holistic heart failure care. People with heart failure deal with a lot of emotional challenges along the way. Can you please each comment, and this year's theme is Get Real. So name it, don't numb it. Can I ask each of you to comment about heart failure care and including mental health and how virtual care may or may not help that, and some tips and strategies. Stephanie, can we start with you, please?
Yeah, sure. Certainly mental health is an extremely important component to address whenever we're speaking with our heart failure patients. And even before, COVID-19, there was a lot of anxiety sometimes that comes along with the new diagnosis of heart failure, right? Because it's a disease that has a very uncertain trajectory oftentimes. And so, the COVID pandemic, I think, really exacerbated those feelings of anxiety, isolation, and sometimes even depression in some of our patients. So whenever we touch base with them, our first question to them, whether it's, through virtually or in person, is always, how have you been? How are you doing? How are you feeling? And sometimes, that leads to discussions about their heart failure symptoms, but oftentimes it leads to other statements about their mental health and how they've been feeling and coping. Now, interestingly, as the pandemic progressed and our patients became a little less afraid to come into hospital, we found that some of them actually prefer to come into clinic to be assessed just so that they can receive that hands-on approach, because I think that there's something a little bit reassuring, at least that's what they told me. They are actually reassured by seeing us in person and having us examine them, which is sometimes, although we try and verbally reassure them and tell them everything's okay, sometimes there is something to be said about that human touch, I think. So we have had more of our patients recently shift over to the in-person stream by request, but certainly when we first started the whole virtual stream process, more people were wanting to be assessed over the phone or by Zoom simply because they didn't want to come to hospital back then. So that's what we found, but I'll hand it over to Wayne and Kyla to comment as well.
Kyla, me, you?
Sure, I can go and then you can follow up. Absolutely. I definitely think that mental health is such a huge proponent of heart failure care. I think it's underreported and undertreated, which is a huge disservice to our patient population. I think moving forward, we'd all love to see more available resources in terms of personnel. For one thing, to be available to these patients, I think is really important. However, one thing that I have noticed is the push from people like Marc and Patty, who are really moving forward on webinars for patients, for caregivers, for burnout, for managing depression, anxiety, and any other mental health concerns that patients have. And knowing that, mental health can be long-standing, but it could be situational as well. It's such a hard thing to grab onto, and I think sometimes we remain too focused on medicines and follow-up plans, and sometimes we don't have the time and the resources to do. I want to thank Patty for bringing that up. That's a really great question, and I think it's something that we really need to work on.
I agree 100%. As a matter of fact, I'm actually have a presentation on Thursday, and part of my presentation is exactly that. It's the mental health issues. Stephanie mentioned about actually seeing patients. Oh my God, when I first contracted heart failure, I needed to see at least my family doctor. And you know what I had? I had a nurse practitioner, not a family physician. So but just that personal touch means so much. One of the messages I'm going to be talking about on Thursday a bit is that we've all heard of Bell Canada's Let's Talk Day. We've all heard about that, and it's so like we're ingrained with it now. So getting therapy of some sort is just so important. And I don't think that every physician is promoting that as much as it's possible. I think that if you're not doing that for your patients, at the very least, find some tools that the patients can look online and read themselves. Nobody wants the patients to become experts in any field, but sometimes just having some contact with information that might be relatable to yourself. Just to finish up, I'll say that I get together with a gang of us at HeartLife on Wednesday afternoons, and every one of us, some have heart transplants, heart failure. There's a whole gamut of patients there, and there's not a lot of us yet. I think it's going to grow, but just having an opportunity to talk to other patients helps a lot as well. Just, we have things in common. I guess to summarize, I would say, when I first had my heart attack, when I saw people, I wanted to tell them my story. Then I learned something important. They don't want to hear my story. The best answer I can give them is, yeah, I'm feeling good. So my other heart patients, they want to hear my story because they got a story that I want to hear, and we can share that. So I hope that makes sense to some people.
That's fantastic. Thank you. I think that's huge advice from all of you. Another question is, and you've all alluded to this, but I'd like to hear kind of some summarized thoughts. Heart failure, similar to stroke, and that's an area I work a lot in, I often call it a team sport. So heart failure is very much a team sport, right? It takes many different kinds of experts. You've all touched upon, the need to involve renal and, even the neuro and, neuropsychology and vascular cognitive. In this virtual world, when you're trying to do care for a patient with heart failure and you're doing a lot of their care virtually, how do you ensure collaboration and coordinated care among the different specialists? Because we've heard a lot of people coming to us saying it's totally disconnected and they feel like they're falling through the cracks. For heart failure, that's critical. So what is your advice on that? Wayne, do you want to start? And then Stephanie.
My simple answer is, I hope you've got a good family physician. If you do, they can quarterback everything for you. And I think that's really the key to it all. Make sure that when you're getting blood tests, make sure that your family physician gets those results as well. The more information the family physician has, the more they can reach out to the specialists that you need for your care.
Thank you, Wayne, for that. Stephanie?
Yeah, so I find that, definitely heart failure is a team sport. We could not do it without our awesome nurse practitioners and also my colleagues who I reach out to on a regular basis in terms of nephrologists and also our palliative care specialists. I didn't talk much about this, but advanced care planning is a critical component of providing comprehensive quality care for all heart failure patients. And we do have a collaboration with our palliative care team as well. Now, back in the pre-COVID days, our palliative care specialists would actually come into clinic with us and see our patients at the same time. So it'd be one visit with both specialists. And when COVID hit, we moved more to a virtual stream. Then the palliative care specialists were supporting us virtually. And the way that we maintain that communication stream is, well, obviously all of our clinic letters and notes went into a common electronic medical record. So you could easily access what, everyone thought when they were assessing the patients. But also what I found was that Dr. Siriani, who was helping us from a palliative care point of view, would actually email us back from time to time after she had touched base with the patients and just give us a 1 or 2 liner email about what they had discussed and what the overall decisions were. So there was always back and forth communication, and I found that that was the same with the kidney doctors as well, that just to ensure that there is good flow of letters back and forth if you're not on a common electronic medical record, and having a great family doctor as a quarterback is also, a key component to that as well.
Thanks so much, Stephanie. Kyla, can you comment on this as well as the role of the nurse practitioner? Because often the person we see first is a nurse practitioner when we enter the hospital or clinic, And then the person that we see last upon discharge is also that nurse practitioner. So what does that role look like in this coordination approach?
Right. So good question. I think it would vary probably region to region. How I function here in my local heart failure clinic is I function very similar to the clinic nurses. Our clinic nurses do independent review of patients and their appointments and touch base with the physician afterward. When I see patients, I have the independent prescribing authority, but if I am needing assistance, which isn't uncommon. Definitely heart failure is complex, so a great team of people to reach over to and ask questions and make sure you're making the right decision for that plan for the patient. So I think it would vary region by region. I can't identify one thing that really stands out. I know that being a nurse practitioner in a specialized line of practice is ever growing, ever changing, ever learning. Trying to sort of keep up with the brilliant physicians that I'm surrounded by and work with, and get to meet sort of as networking continues through this world. But keeping, a lot of my background nursing philosophies and approach. Just kind of going back to the last question about having a good quarterback as your primary care physician, as nurse practitioners in our community do function quite well in that role, which I'm super thankful that we have wonderful nurse practitioners in Manitoba that function in that role in place of primary care physicians. So it's lovely to have that quarterback on your side. A little bit more of a challenge for some of our folks that don't have primary care providers, usually up north or rural. So that extra challenge on coordinating care comes from whoever is seeing the patient, whether it's physician, nurse practitioner, or nurse.
Fantastic. Thank you all for that. A couple more questions have come in. One is about different home monitoring equipment and devices, that can help report data back to the team. Are there ones that you recommend patients to have, or is it better for them to be dealing individually? Is it not something so broad that you really have to talk individually with patients about what their needs are? What are your thoughts on that? Maybe Stephanie, we can start with you.
Oh, sure. I think it depends on where you are and which institution you're being followed by. There are some institutions that have access to high-tech virtual technologies, things like, the Medley app telemonitoring program, which was piloted and developed by the UHN in Toronto. Or there's CardioMEMS, which is a little bit more invasive, but you can insert kind of like a pulmonary artery catheter device that monitors fluid levels and pressures inside the heart. So it can get as fancy as that, but truthfully, those devices are really hard to access if you're outside, very, very, very specialized centers. And for the vast majority of people at home who are doing virtual assessments, really, the basic critical things that you need to do is to get a weight scale. It doesn't need to be fancy, seriously, like just a $10 scale from the Shoppers Drug Mart or pharmacy will do. What you have to do though is every day weigh yourself first thing in the morning, after you go to the bathroom and before you eat breakfast, and write that down on a piece of paper. Literally, it doesn't have to be fancy at all. It could be as simple as that. Piece of paper, scale. If you have a blood pressure cuff, that's bonus, but really that's not necessary. We will be able to tell whether things are going off track in terms of your clinical status if you're able to get blood work for us, and then we can track what your kidneys are doing and your potassium and sodium levels. So those are the basic necessities. But obviously there are other centers that have more resources, and in the context of clinical trials, etc., are able to access fancier telemonitoring devices. And then there's also the telehealth home care in Ontario that we have that send patients home with kind of a Bluetooth enabled scale and blood pressure cuff that automatically gets those readings and transmits it to their physicians. That can be helpful too, but like I said, not really necessary. It's kind of a nice to have, but even if you have none of the above, you can get by with a scale, piece of paper, faithful recording, and bonus blood pressure cuff, and just writing everything down and having it ready for us at the appointments.
Thanks, Stephanie. Just leading into that for Wayne, how do you keep track on a daily or weekly basis? And through everything that you're going through, how do you remember that and get into a routine? And has it worked for you, or what's worked for you?
I monitor things a little bit more closely than that. One of the reasons is because when there's a change in meds, sometimes it affects me in a certain way. And because of that, I like to have a bit of an idea what my blood pressure is, what my pulse is, even the oximeter, my weight, all those sorts of things I have at home here, and I do monitor those every single day. I've got my Fitbit here, and after I go for a walk, I come back and I check my pulse, and I see how long it takes before it starts to reduce. Right now I'm at 54 beats a minute. But those are tools that I think are available, and I highly recommend them whenever possible, because it does give you a bit of an idea how your system is working if you're following on a kind of a regular basis. And because of that, it'll give you an idea as to when you need to call your doctor or not. If you're having a bunch of great days in a row, hey, that's good. Just keep monitoring things and enjoy your day. But sometimes you start seeing your fluctuations there, and you know that time to call Stephanie. Kyla?
Yeah, I agree. It doesn't have to be fancy, that's for sure. My number one is always a scale. My number two, at a close second, is a blood pressure machine. It's helpful with the titrating of medical therapy to guidelines. So we're able to titrate their therapy to what guidelines say, and then get their ejection fraction reassessed according to guidelines, and then make a formal plan from there in terms of device therapy if it's indicated. But definitely a scale. And again, yes, doesn't have to be fancy. Ideally, if somebody doesn't see very well, then not one that's digital, that they can't read the numbers unless they have somebody who can read the numbers for them. So, so we've worked with patients through little things like that. Blood pressure machines, if they don't have one and can't acquire one, if somebody could borrow it to them. So working through little challenges like that. I have had some patients ask if it's worthwhile to get an oximeter, but if they don't have a blood pressure machine, then my preference is definitely go for the blood pressure machine, not necessary for the oximeter. More recent questions in terms of sort of the home mobile EKG apps like Cardia Mobile, again, not absolutely necessary, nice to have, but then you start looking at the need to have, and definitely scale blood pressure machine is lovely. And always thinking of ways to get everybody one.
Great, that's awesome, thank you. Yeah, there's so many people who have gotten gadget fixated these days. With the virtual care, we hear all about, and not just for healthcare, but remote gadgets have become the thing, so people are really into it, and there's a lot flooding the market. So I think this is great advice. People can go and look at the Heart and Stroke website, where we do have listings of blood pressure machines that are recommended by Hypertension Canada. We're now almost out of time, so I have one final question. Before I do that, I'm going to thank everybody. Thank my partner, Marc. Thank our three amazing speakers. I'd also like to thank our team member, Rebecca McGuff, who's been behind the scenes running all the technical today and working with the speakers. So Rebecca, huge thanks to you as well, and to our Heart and Stroke team. My final question that I'd like to leave you all with, including you, Marc, so you can have the last word, Marc. For each of you, can you make one comment about what would help somebody as they transition to virtual care? Sure, Wayne, we'll come back to you. So for each of you, just to take 1 minute, because we're almost out of time, what is your one piece of advice for people when they are engaged in virtual care for heart failure? Kyla, why don't we start with you? What's your parting advice?
Keep evolving. Simple.
Stephanie? Simple is a great, thank you. Stephanie?
I think heart failure care is evolving such that virtual assessments are going to be a great alternative for stable patients in the future, even beyond the pandemic. I think, the high risk and decompensated patients should still be seen in person, and don't delay care. If you are feeling unwell, please come and get assessed, whether it's virtually or in person.
Thank you. Wayne, what is your tips for people to be good participants in virtual care? What do you leave them with?
Well, I think the first thing is, with your loved ones, say thanks to them every single day. Because that's really the key for me anyway, because they're the ones that know how I'm doing, and they can see how I'm feeling, and maybe give me a little bit of tip, or just tell me, Wayne, go have a nap. We can tell you're tired. Small little things like that to me are important. And listen to the doctors, listen to the nurses. The healthcare system in Canada is great, and if you listen to what they're telling you, I think you'll do well.
Amazing. Thank you. Marc, would you like to wrap us up and close us out?
Yeah, thank you everyone for that. I mean, I think my one piece of advice would be, be more like Wayne. He definitely continues to inspire us. Thank you, Wayne. Thank you, Stephanie. Thank you, Kyla. As from a physician perspective, I would say for physicians, healthcare professionals, listen to your patients and their caregivers, understand what works for them, because it is a challenging time, and work within their means and their parameters. From a patient and caregiver perspective, Wayne, you're right, incorporate the caregiver into these conversations because they are so important to us. Write everything down, and don't be afraid to ask questions, and ask again if you don't have the answer, because it is your care, and it is important, and you have to be engaged. I'll leave everyone. Patrice, thank you for involving us. Thank you, Heart and Stroke, for involving HeartLife Foundation. And on Thursday, as Patrice mentioned earlier, we have our full-day workshop, Engage, Educate, and Empower, where we will have both insights from healthcare professionals and patients and caregivers about their journeys, medications, devices, and stories. Thank you all for attending today. Thank you again, Patrice, and thank you to our wonderful speakers.
Have a great day, and happy Heart Failure Awareness Week, everyone. Bye.
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 Thanks.